No need
So
for
just
any
a small,
formality.
yes. So good evening, everybody. Today we again are lucky enough to have Dr. Anupam Jena with us, and every time, I hope it will be a very educative session. Dr. Anupam sir always tries to concentrate on practical things and learning by doing, and that's what we'll be seeing how he has developed his expertise and knowledge in mitral valve interventions. So over to you, Dr. Anupam sir.
Thank
Thank
you,
you.
Sajatya, and good evening, Ajay sir. Good evening, Kirti sir. When we talk about mitral valve interventions, oh, just a second. So when we talk about mitral valve interventions, transcatheter intervention, BMB comes first, but I think I am not the right person to talk about BMB. There are so many people who are so much more experienced, who have seen so many things in life that I am not the right person to talk about BMB. I hope my slides are visible.
Yes,
Absolutely
visible.
fine.
Yeah, so we'll see some structural interventions, mitral valve interventions, case-based discussion. So I would like to begin with mitral paravalvular leak. I mean, there is a problem that it affects around 5 to 10% of surgical valve replacements. Clinical presentations, basically mostly with heart failure, can be also hemolysis. Some of the challenges are a redo surgery. Mitral valve redo surgeries carry a little higher risk. Percutaneous closure is class 2A recommendation. So I would like to talk about the workflow and how to image. 54-year-old female who underwent MVR in 2010, and she more or less remained symptomatic after surgery with dyspnea, palpitation, and her paravalvular leak was diagnosed early, but she was taking heart failure medications and she was going on. Then finally she landed up with more or less refractory symptoms, and then she was advised for a transcatheter closure, and then she was referred to me. So pre-procedural imaging is the most important part in mitral valve interventions, because without a proper imaging, mitral valve interventions cannot be done. The fluoro is not much helpful. Mostly it is 3DT needed for mitral valve interventions. And preferably we need the surgeon's view, that is the NFAS view from the LA. Then there we try to localize the leak. Mostly, in majority of the cases, there will be anterior or septal, posterior or lateral will be seen in some cases also. So clock orientation also helps us to see, and also during procedure with the live 3D uh, and 3D zoom, we can look into the areas where our catheter is going. Different morphologies. Another challenge is the morphology is not always round. It can be crescent, it can be slit-like, where residual gaps will remain, and they are very prone to develop hemolysis, the residual high velocity jets. So this is her trans esophageal echo, and there is a, so this is the paravalvular leak. Then this is the 3D zoom. This is the 3D view showing that the paravalvular leak is at around 1 o'clock position. Stopped. It is this is the paravalvular leak at 1 o'clock position, and it is again towards the septum, anterior location. So a closer view of the paravalvular leak. Even the 3D color also shows, I mean, this is a beautiful demonstration. Usually we get very hazy images in color because of so much of stitch defect. But here we could appreciate the round defect and the clear jet. It was coming around 6 millimeter. in the 2D image. So he took up the case, and for mitral valve interventions, anyway, this patient needs a live guidance. So mostly these cases are done under GA. And when the patient is under GA, it is better to do a transseptal puncture under TE guidance, because we need a mid fossa and posterior orientation of the transseptal puncture. That is the best place for most of the mitral valve interventions. So as we see that the valve and taking all the landmarks. So choosing our approach, which is the best approach? First is antegrade, that is the transseptal. It is preferred for most defects, especially for septal ones. And in the anterior approach or antegrade approach, we need these steerable sheaths. Without these steerable sheaths, it becomes very difficult to actually point to the defect and then advance our wires and catheters. Usually requires a good transeptal height. Puncture of the transeptal puncture should be a little high, mid or superior part, because we need some room to maneuver the hardware inside the LA. Sometimes the problem is to create a rail to support the delivery system. Then retrograde or transapical. Transapical, it is can be used, preferred in lateral or difficult to access posterior leaks, where sometimes it is very difficult to access with an antegrade technique. So there is a direct LV puncture and provides a shot to the valve. Usually, crossing the defect, sometimes the jet will carry the wire through the defect, and then more or less the procedure becomes a little straightforward. However, little invasive and bleeding surgeon's backup is needed. Then retrograde, that is transaortic, again similar to a transapical. However, here manipulation can be a challenge. So retrograde femoral transaortic can be done, but there we don't have control over the wire usually, and we have to rely solely on the jet carrying the wire. We can try with a Terumo wire, like a 1/8 Terumo or a 2/5 Terumo. Even sometimes PTC wires can be there. In this case, with 3DT and localization, we could cross the defect antegradely. So this is a straight tip Terumo, and we could cross the defect. Steerable guide catheter, steerable sheaths like Agilis is more or less a must for such procedures. Without that, it is very difficult to point our catheter wires into the defect. Then after we crossed, we passed this JR catheter, and then the JR catheter was taken to the aorta, the usual procedure, stiff wire, then the delivery system, and we closed the defect with an AVP2. I think 8 millimeter AVP2. This is after the closure. So this is the picture from the LA side, and this is the picture from the LV side. And this is just the 3D image showing both the LA disc and the LV disc of the device, and this is the mitral valve. Post-procedure echo showed that there is some valvular regurgitation, but there is no paravalvular leak, so there is no MR anymore. So imaging is definitely the most important part of this type of mitral valve interventions. Without a live 3D TE, it is very difficult to do. We can choose a transseptal versus a transapical based on the location of the leak, whether septal or whether posterior lateral. There are no dedicated devices, but mostly AVP2, AVP3 are generally used. And one of the important thing is that we have to go, there is zero tolerance for impingement, because if the disc of the device impinges on the valve movement, then it becomes catastrophic. So we have to withdraw, try a different device probably. So always check for valve motion before releasing the device, both with fluoro and with TE. We should also check the mitral valve gradient before releasing the device. So that is about mitral paravalvular leak. I think Ajay sir should comment. We will stop and discuss and then we'll
Yes, yes.
proceed.
So I had one question, like how do we decide? Like this patient had valve implantation in 2010,
Hmm.
and now I guess this is she presented at least 10 years or 15, 12 years
No,
after
this was done in 2018.
18. Okay, okay.
So
So
what happened after she was following up with the surgeon and she was getting these diuretics and heart failure medications, but she was always very symptomatic. However, she was told that she will need a redo surgery for that, and she was not willing. But finally, they gave the option. The surgeon told that, okay, you go and consult a cardiologist. Then they came to me, and that is how this procedure happened.
So suppose the valve if it's if we have implanted the valve surgically, surgeon has implanted a valve,
Hmm.
and immediately after that, if we start having symptoms and we find that there is paravalvular leak,
Hmm.
means we can say that this is the cause and effect going on. But
Yeah.
say if suppose patient presents down the line,
Hmm.
sometime after the procedure, like how do we understand whether it's the leak or whether there is some cardiomyopathy or heart failure due to other causes going on? Do we need cath studies, or do we is there any or is it purely clinical that a person is having recurrent ADHF and then we say that okay, the leak is responsible?
Yes, very good question. Suppose the symptoms start appearing after 5 years, then probably we need to look at other causes also, like whether it is an independent process or what is the size of the defect. Because in a paravalvular leak, the defect will remain. I mean, there is absolutely no. It is not a progressive disease. It is always the same. But maybe suppose some supurated coronary artery disease or something which has increased the LV-EDP and that has worsened the heart failure. Definitely, we have to look at those factors also.
Fascinating discussion. Paravalvular leak has essentially two or three different types of natural histories.
Hmm.
The first type of paravalvular leak is what occurs immediately following surgery, and that is
Hmm.
because one of the sutures is not okay,
Hmm.
and that has given way. Second is if you have endocarditis post-op,
Hmm.
and sometimes that can result in a paravalvular leak. The third type is what Anupam has shown. That means there's a small leak, and over time it grows and it becomes large. The edges become fibrosed, but the leak is significant and it remains. Now, in
Hmm.
the acute case, there is an issue because sometimes you have to do PET scans to make sure that there is no endocarditis. Patients are quite sick sometimes if they have moderate to
Hmm.
large leaks. And before one closes them percutaneously, it is mandatory to be sure that there is no endocarditis happening.
Hmm.
If you do have an endocarditis, then it's a disaster and you have to actually resort to surgery before. And second thing about there is no one way to approach a paravalvular leak. So
Yes.
even an interventional cardiologist will probably see maybe four or five over one or two per year, which will actually require intervention. And you have to tailor your approach to what is that particular case and the particular anatomy. And I think Anupam has shown a beautiful case. About 6 to 7, 8 times I've had to resort to a transapical puncture.
Hmm.
And that is because there was one patient with a DVR, and she came back after 4 months, and she had basically combination of hemolysis, severe PH, and heart failure in atrial fibrillation. And we did a transapical paravalvular leak closure for her because it was very difficult to get a transeptal puncture and enter perfectly between the two mechanical valves
Yes.
without getting into one of the other this ones, whereas the transapical route was absolutely straightforward and easy.
So,
And
sir, I mean, from the transapical route, it is the jet which carries the wire, or you do some maneuver?
no, no, you have to do it under transesophageal echo. You see
Okay.
the jet, and it's a combination of fluoro and echo. So now we have got something called echo nav. You can actually
Ah.
superimpose the
Hmm.
echo onto the fluoroscopy.
Hmm.
It's a fabulous technique, and it really makes a job very, very simple.
Yeah.
Use it for all paravalvular leaks, for mitral valve and valve. For towers, we are not yet putting, TE probes, so we don't require it. But for wherever you have a TE probe and you need fluoroscopy, that is a fantastic technique. And the devices also, apart from what you have mentioned, the ADO2 and the Konar devices are also very good. And you
Okay.
have to see what you require. Sometimes AVP2 is not so easy to get. You don't get it in the sizes that you want, and then you don't get the access. And lastly, delivery of your catheter, that can sometimes become a challenge because your wire will go, your MPA catheter will go, your slip cord catheter will go, but it's very difficult for the delivery sheath to follow that. And sometimes we resort to the Neuron Max sheath, which is the with the neurologist use. That's a
Okay.
beautiful sheath. It has got 6, 7 different transition points, and it's very easy to track over anything. It goes over a coronary wire with a balloon on one
Okay.
in a
Okay.
wire, put in a balloon over it, and over the balloon sleeve the Neuron Max sheath. So you have to see what is the anatomy and use the sheath accordingly. And but you can plan if you have a nice tea, definitely. But a beautiful case. And what else is there that we can speak about parabolic? Yes, the location of the puncture. Location of the central puncture, as Anupam has correctly said, usually we use a superior and maybe a slightly anterior or posterior, depending on the location of the leak. But if you're a little bit more superior, then it becomes easier for you to turn your Agilis sheaths down to face whichever side, whether it's the lateral or the medial side of the mitral valve that you want to face. The aortic paravalvular leaks are usually cross retrograde, so you don't need transeptal for them. It's only the mitral paravalvular for which you need the transeptal. And now our transapical has become once in 4 or 5 years.
Okay.
The transapical punctures that initially we used to do purely percutaneous punctures, and then one patient we hit the LED while entering the LV, and we ended
Okay.
up with a huge hematoma at the apex. It was a wraparound LED. So now we just get the surgeon under local anesthesia to do a small separation, and we puncture under vision. And we close our puncture with an angioseal. It works like a charm. It works very, very well. People used to try ADO2 and all, but in our hands, the angioseal works very well.
Oh, that's a very nice idea. So we don't need the surgeons.
You don't need the surgeon. You don't need the surgeon. But now I've started using them for local anesthesia. He just takes us, he just separates, he shows you the LV. You can see the epicardial vessel. So you can avoid the epicardial vessel at the time of puncturing.
Okay.
That makes it little easy for you. In any case, the patient is on GA, so it,
Now, using an angioseal is a very nice idea.
Yeah. So, I mean, I use angioseals routinely for closure of apical punctures. It works really, really well. Very easy. People use ADO1 device also, but the angioseal is the best because most of your devices will easily go through maximum 7 French. You can easily close it.
So with an 8 French angioseal, we can easily.
You can use a 6 French and a 7 French sheath also, even that will close. It closes very, very well because the step, you have just deploy the step correctly inside. And it closes perfectly well. I mean, in fact, I did 2 cases with Smith in Raipur also. I went to his.
He was saying.
Cases in Smith.
I know. Yeah.
Is there a chance for the step to attach to one of the cordy or something? The
You have
angioseal
the
step.
sheath inside, no? The angioseal sheath is inside.
Okay.
So there's no problem. You just see where you're getting the jet and you pull out the dilator and it is sitting perfectly there. So you go inside, you get the jet, you pull out jet stops, go back until just where the jet comes. Then your left hand fixes the angioseal outer sheath, pull out the dilator, deliver your step. It was not going to catch any cord. There is no problem at all. It's absolutely straightforward, simple. In fact, I remember 4 years back in NIC, somebody put a pigtail into the RV while trying to do a pericardiocentesis and that closed with an angioseal.
Yeah.
It's a very, very nice device and you can get out of trouble many times. The only problem with the angioseal is that once you fire it, after that, you're lost. If it fails, you're in trouble.
Because we don't have any more excess.
Unlike the ProGlide, in which you can put the wire back inside.
Here there is
what
no
we used to do is I would put 2 wires. A wire remaining inside can close. So you put 2 wires inside the sheath, put one angioseal over one sheath, leave the other wire there. Once your angioseal is fired, it's okay. then you can pull out the second wire and just compress it locally.
Yes,
It
yes.
works perfectly well.
Mm-hmm.
And if it doesn't work, then you can always put a sheath back inside it and then send the patient for surgery anyway.
Mm.
So
Right.
these are
Look,
Yeah.
Crescent leaks are.
Hello, sir.
Yeah, go ahead. Go
Can
ahead.
I add something?
yes,
So,
yes,
hi, sir. Nice case.
Mm-hmm.
So, from last 2 years, we are regularly doing around one paravalvular leak or like 1 to 2 per month at AIMS. And what we not put sheath to put the device, but we put the guide, like 7 French guide. Most of the time, we use the guide only. Normal
Mm.
guide, the JR guide, we put the guide over the stiff wire and then we put the device through the guide. So there is no
Ah,
junket
it
of
can be
sheath.
done.
Yeah. So
absolutely.
the sheath maneuverability is less. Guide maneuverability is very good. Like
Mm.
JR diagnostic you are putting, like the way the JR will go. Regarding sir apical puncture, we also did only one apical case. Rest all by the transeptal. I think the team also matters. It's like it needs a lot of effort from both the operators because it takes time to one we push the wire and other one will manipulate the guide inside the agilis. So and regarding the Sojitya sir's question is most of our paraviral leaks are presenting around 8-10 years after the surgery. The maybe it's because and the presentation is hemolysis. So if the defect was at the beginning, then hemolysis should be at the beginning. And we were also not able to explain this why the patient are presenting after 8 to 10 years. This is what we also discuss here. And the only contraindication from our side is when the paravalvular leak occupies half of the circumference or more than two-thirds of less than one-third. We attempt it more in one-third to half. We just try to see whether this dehiscence of valve is there or not, and more than half we never attempt. In last case, there was total bioprosthetic valve dehiscence, and it
Yeah,
behaves like a
those,
severe.
yeah, yeah.
It behaves like a severe MR. So
Mm-hmm.
presentation varies from acute to subacute to chronic.
Yeah,
I think, as I said in the beginning, it is important to rule out endocarditis
yeah, yeah, yeah.
because that is the usual cause of this kind of leak. What you're describing, dehiscence and this, is because endocarditis is occurred. So that is
Yeah.
contraindication for a closure. You shouldn't try to close an endocarditis valve. The guide is a very cheap way to go ahead and deliver.
Mm.
But sometimes the guide of the JR, which is what you usually use, is sometimes a little stiff and it doesn't go. So most of the time it will work, but if not, get the Neuron Max sheath. It's very nice. It's very torqueable and it goes over the smallest wire that you have very easily. It's
Yeah.
basically meant for neuro intervention because it goes inside the brain in various small vessels and it offers the advantage of lots of lumen inside, so you can deliver large devices inside which will not go in a 7 French guide or an 8 French guide.
And
Fantastic. I'm
Anupam
sure
sir,
you
you can
have
proceed
more
now.
cases to show us. How many
Yeah.
need?
Yes, yes.
Okay. So again, I mean, a case of severe MR.
Yeah.
So 70-year-old female presented with refractory heart failure, multiple hospitalization, more or less NIV dependent because of the heart failure. And this is the extent of the MR. We see that there is a torrential MR and the LV, global LV ejection fraction is definitely less than 30% and see, fits into the coaft population. And we decided that, okay, as we know that already the co-opt results have come up in New England Journal of Medicine, the 5-year follow-up and hospitalization, death, all-cause mortality, heart failure hospitalization, everything is better with mitral TR. Okay, so I think all of us are conversant with the system, so there is nothing more to say. We can hear more from Ajay sir also. So it basically comes with in 4 sizes, the NT and XT.
No, Anupam, it is meant for everybody else. You must speak about this. Just speak about the system.
Yeah, thank you, sir. So basically, this is the system. Here we have two things. We have the clip delivery system and we have the guiding sheath. So this is the steerable guiding sheath. And there are 14 types of movement. So we can have the medial and lateral. This is the ML. Then we rotate the system for an anterior and posterior orientation. Then we can push the system, and pushing the system will bring it more laterally, and pulling will bring it more medially towards the, I mean, anterior and posterior, sorry, anterior and posterior. Then finally with the knob, with this knob we can gain height or reduce height. So these are the basic movements that we need to see. Then the NTR and the XTR, what are the differences of the NTR and the XTR? Basically the difference is in the size of the clip, that is the 6 millimeter and the 9 millimeter. Then there are NTW and XTW, where the width of the clip 4 millimeter and 6 millimeter. So these are the four different iterations of the clip. And the mitra clip system especially has an independent grasp, so we can independently grasp. Now we have done one case with MyClip also. So MyClip is also a very good device. More or less it is a copy of the mitra clip. The levelings and everything are almost same. There they have changed the angulation of this tethers. So I mean they are more like 45 degree. Here they are like 30 degree. So a little more open, little opened up teeth. And with, like all mitral interventions, again everything begins with a good transseptal puncture. So how to get a good transseptal puncture? We, in the bicable view, we see the height. So when we are coming from the SVC, we see the first stenting, then we have to adjust the height accordingly. So you see the first stenting, so we can go for a superior, posterior, and superior. So this gives us the height. That's okay. This is the superior side. Or if here is if we get a very thick septum, then maybe we can come a little bit. We can come up to the upper fossa ovalis, but we should avoid a inferior puncture, because again this guiding catheter, guide sheath needs a lot of room. At least 4 centimeter height is what we try to achieve. For a functional MR, a 3.5 is okay, but for a mitral valve prolapse and all, the height of the puncture is absolutely necessary, because the coaptation plane is higher up in a mitral valve prolapse, whereas in a functional MR, like in this patient or heart failure patients, the coaptation plane is little lower. Then tenting in the mid fossa. Then in the I mean the short axis view, we go to the posterior side. So this is the aorta. Here we give clockwise torque, and with the clockwise torque, we see the orientation of the tenting, and we try to go as posterior as possible. Finally, before puncturing, before entering, we have to see the height, and height is seen in the 4 chamber or 5 chamber view, and it is measured from the coaptation plane to the tenting area, and the height optimally should be 4 centimeter or more. In functional MR, 3.5 is also acceptable. So these are the things we have to see. We have to go for a superior or mid fossa puncture, a posterior puncture. Then we have to see the height of the puncture in the 4 chamber view. After that, we go for the transseptal puncture, and then we can see the entry of the, we should in fact follow the entry of the guide sheath into the LA. So placement of the guides. So, normally what I do is I put a safari wire in the LA. So with a safari wire inside the LA, it is easier to pass the guide system. And once we pass the guide system, there are we have to check. Then we need to flex towards the valve, and sorry, why it is not playing. Okay. So then we have to go to the orientation of the clip. We have to see the orientation of the clip in the long axis view. I mean, normally we use an explain view, commissural view, and in the commissural view, that is usually 60 degree, and there we put the explain so that we get the simultaneous commissural view and the long axis view. And in that we try to form the trajectory. So in the trajectory, we want to align the clip to the long axis of the LV in both the views. We try to align. Here we can go for different movements. For example, whether we want to go medially or laterally, anterior, posterior. So these are the things we need to fix here. So this long axis view will give us idea whether we want to go anterior or posterior, and the commissural view will show us medial and lateral. Then once we are sure about the trajectory of the clip, then we try to partially open the clip, advance the system. And once we advance the system, then we switch to 3D, because what we want in 3D is for the clips to be perpendicular to the closure line of the mitral leaflets. So that is, as we can see here, that this is the closure line of the mitral leaflets, and this is the clip orientation. So this is what we want. We want a perpendicular orientation. Then we advance a little bit into the LV, and after advancing, we try to grasp the leaflets. We can go for independent grasp. We can I mean put or it is called grippers down. So we put the grippers down, and once we put the grippers down, then we check whether we are adequately capturing the leaflet or not. And once grippers are down, we check for the mitral regurgitation, and then after we are sure, we go for releasing the clip. In this particular case, what happened is there was still a significant leak, because the extent of mitral regurgitation she had at baseline, it was very difficult. I mean, we expected that she will probably need more than one clip. So there is still a big jet remaining here. So we took a second clip also. But up to second clip is okay. But if we have to take a third clip, then the chances of mitral stenosis becomes a little higher. So even after second clip also, before releasing the clip, we have to be sure about the mitral valve gradient, so that we should not artificially produce any mitral stenosis. And in this case, after two clips, her torrential MR was reduced to, you can call it moderate eccentric MR. The long axis, the plaques view is showing little less. However, the fourth chamber is showing eccentric moderate MR. There was some pericardial effusion. We didn't drain it. I don't know, it might be because of some appendage injury or something during manipulation. But anyway, it did not progress. We kept a close observation for this pericardial effusion, and she was discharged after 2 days. She has been under follow-up for 2 years. She is okay. I have seen a good thing is that I think sir will comment that after MitraClip, actually her ejection fraction has improved a bit. Maybe around now it is 35%, and functionally she is much better. So even though MitraClip, like TAVR, is a case, but MitraClip is not a case. It is basically a process in heart failure management. So I mean, putting a clip is not the solution to the problem. It is just a temporary measure till more definitive therapy like LVAD or heart transplant is done. But in this case, her ejection fraction has shown some improvement. Her functional class is much better. So she is doing okay, but I don't know. She has not come up for follow-up in last 1 year. I don't know what has happened. So this is about MitraClip. So far we have done 3 cases, 2 MitraClip, 1 MyClip.
So, hi everybody.
Hello, sir.
Hello,
Hello.
sir.
Sorry,
Good evening.
I'm late, but yeah, hi, good evening, Ajay. So, Jatya, Tenmoji, I can see Saurabh is there. So, just one concept which I have always struggled about MitraClip.
Uh,
In this patient who's got a very bad LV,
hmm.
a dilated annulus, What we have done is we have tried to narrow the mitral orifice.
Yes.
So that would
TROE.
mean, correct? So that would mean that whatever blood is coming from, the lungs into the LA, that would find it difficult to go down, correct? And when the ejection fraction, when the heart ejects, the amount of blood which it was pushing into LA to get free, more EDP should rise. So with this concept, whatever in Delhi, you keep on seeing these cases. I have not done any, of course. So there are two categories. One is like yours, which tends to improve. And second category, which becomes nasty, even more bad.
Exactly, sir. So afterload mismatch is another problem that we need to, because basically what we have done is we have increased the LV afterload.
Yes.
And now LV was freely emptying into a chamber, and now we have stopped that. So I have a very bad experience of closing VSR in a patient. Normal LV function, we close the post MI VSR, and after 3 hours, his LV was 15%. So it was a case of afterload mismatch. So definitely afterload mismatch is a problem. I mean, with 3 cases, I cannot comment about that, but maybe we can invite some
Ajay, any
comments
idea?
on that.
Any comment on Ajay?
So two things. Number one is the natural history at which time the patient is intervened. If the mitral clip is done so late that irreversible remodeling has taken place, in that case, sometimes they don't benefit, and that's why the difference between the co-opt and the
MITRA-FR.
MITRA-FR, the European trial.
Hmm.
But the whole idea of the mitra clip is to try and reach a hemodynamic state where the LA mean actually drops. You are supposed to monitor the LA pressure and the PA pressure. Sometimes you will put an additional catheter inside your sheath or take an additional puncture or something so that you do not create an elevation in LA mean. As far
Yes.
as the forward flow is concerned, you are supposed to use good quality vasodilator so that this LV, which was, as you said earlier, unloading into the LA, now unloads into the aorta, so that you are able to get good vasodilatation. And that is part of the process. Creating a functional mitral stenosis by putting too many clips or narrowing the orifice so much that you actually create a small gradient is a disaster. That is the exact opposite of what you want to achieve when one is doing a mitra clip. The LV also becomes less commodious because of the regurgitant fraction, which was earlier filling back from the LA into the LV. That also becomes less. So that is part of the beneficial remodeling of the LV that occurs after the reduction in the grade of MR. But you cannot reduce the grade of MR at the cost of increasing the LA mean. And that's the hemodynamic achievement that you have to get with a good quality mitra clip procedure. So that's the best answer that we can give. And the only thing, two things for Anupam's case, the manipulation of the clip from the LA into the LV is crucially important that it is done under guidance of transesophageal echo.
Yeah.
With whatever other landmarks you have, because the clip is actually not so atraumatic and it goes and hits the LA appendage or it hits somewhere else, and then you end up with something else that you are not really bargained for. It's very, very important. And we will use the LA mean as far as possible. As far as possible. If required, you will put a PA catheter also and try and see what is happening to the PA pressures also, because the hemodynamic achievement or your hemodynamic endpoint has to be very carefully measured. People who are doing 15, 20, 30 clips and all, yes, they just go ahead and do it and come. But we are still in the 10 to 20, 25 stage. So for us, every case, we will study very carefully before doing it. And we are very, very careful whether you plan in advance. I think this will require 2 clips. I think 1 clip might be enough. I think I will do an A2P2. And I think I don't need, oblique clip, or I will plan to put it that way, etc.
What is the anticoagulation you use in these cases?
You just use heparin during the procedures. After that, you do not require any anticoagulation. I mean, if somebody has got atrial fibrillation, which is often the case, that is a different point of view. I mean, you just go back to a NOAC. We don't use NOACs during the procedure. because in case you end up with any bleed, NOACs are notoriously difficult to reverse. Whereas if you have acetrom or heparin, you can just reverse them like that. No problem.
Can
And
pericardial effusion occur because of reduction in, not because of any puncture of any side, but simply because the size of the
No, no,
LV
no,
of
no.
the...
And here I think it has hit some appendage or something.
Absolutely right. It is
so,
appendage is the thinnest part of the heart, and you just touch it with a thermo wire. Sometimes you will end up with a damage.
Mm.
You have to be exceedingly careful while manipulating in the region of the LA appendage.
yeah, very nice case, Anupam sir. I just one question. As Dr. Ajay sir has suggested us, we should not go for mitral clip in late stages, but sometimes clip has been advised in asymptomatic severe MR and in the early stage of MR, like suppose patient had DCM, early DCM, diagnosed DCM, advised because we have seen that reduction of MR after the heart failure therapy. So, what is the sweet spot? It's very difficult to say in the mitra clip. This is what I feel. So, how
I
will
think
you?
asymptomatic, we shouldn't, it's out of
Yeah,
So,
out of the
absolutely.
discussion.
Sorry to interrupt. Okay,
Asymptomatic severe
Saurabh.
MR is out of discussion.
So,
Mitra clip is meant for patients for whom A, surgery is contraindicated, B, are severely symptomatic,
Yeah,
meet the hemodynamic profile of acute severe MR with, I mean, severe is not acute, but severe MR with heart failure, with elevated PA, with elevated LVEDP. It is not
yes.
for, we
so,
can
so
discuss all the theory, but I
you
think we
all,
should stick to the
you all guys,
patients.
you all guys are talking science. So I was in US 2 months back, and this gentleman is doing three, four mitra clips a week.
Hmm.
So I said, I want to see how come you are able to do so many.
Hmm.
So this is what Saurabh was saying. Anybody with grade 2, grade 3 MR and a non-ischemic cardiomyopathy, tuck, tuck.
So the patient,
So,
that was a very
and the
good.
reimbursement is phenomenal. They are rich.
Huh.
No, no, sir, they are not rich. They are all in debt. The US medical
Doesn't
system
matter.
is $5 trillion in debt. It will
Doesn't
take them
matter.
30 years to pay back what they owe if they stop working on credit.
Amazon has always been in loss, and yet Jeff Bezos is the richest man, right?
In TCT, they presented this Sapien M3. So the encircle trial. So there's a new, they are for non-MAC valves.
Hmm.
The Sapien M3 has come up, which you can put an encircling device
You
and
can
then
put an
include it.
encircling device. Yes, yes. I saw the trial being presented. Yes.
They, as usual, they say very exciting. All the results are very good, but I don't know actually.
No,
So
so
in
when you travel to Europe and you see a mean gradient of 25 across the aortic valve being treated with TAVR,
Hmm.
realize that there is
Well,
more to it than that.
Yeah.
several years back, there was a concept that after you do PCI in acute MI, if the LV is 20-30, you take a catheter through the IVC and just drop AICD inside, just like we are doing this, the leadless pacemakers. So everybody said in Europe, oh, very exciting, very exciting. We'll be able to do it in 5 minutes. And the concept bombed.
Yes.
It is going to happen every time, and we'll be out of fashion every time, especially those from PGI. It's very hard to digest all these things.
Yeah, I mean, at one point we have to think that, I mean, what is the patient ultimately is going to achieve? Why treat an asymptomatic MR with clip?
If you want to
I
become a chairman,
Next.
if you want to hold meetings, then you have to do that.
Okay, sir, we are happy.
Yes, we can proceed.
Ah,
So, sir, my question
we are
is,
satiated.
so my question is, what is the LV you take before, and what are the treatment you already patients on that treatment? After that, you decide for the clip.
No,
So,
no,
how will you decide?
it is all about the heart failure. It is not
Yes.
only the LV. So the heart failure, if the patient continues to be NYHA class 3 and definitely there is a severe MR and you have tried the 4 drugs, you've tried everything, still a patient is symptomatic, severe MR, then probably we
No,
plan
but
for it.
Saurabh has a point. If the LV is more than 65,
Hmm.
then he is not likely, then you have to think very
Yeah.
hard before doing a clip.
Yeah,
हाँ
in those cases, maybe surgery. Why not surgery? If the LV is 65% and
correct sir,
No,
correct.
no, I mean LV dimension is 65.
oh, okay.
In
LV
my
dimension.
hospital, transplant is done for 30 lakhs.
Hmm.
Mitra clip used to cost 25 lakhs after cutting down cost everywhere else. So in my hospital, it was very difficult to make a decision because you're
Hmm.
palliating somebody for 18 months. 2 years later, most of them are back in the same state.
Same state.
So you have to think
Absolutely.
very hard. Whereas in an early, in a coab subset, actually, if you do a nice clip, they go out to 5 years without any problem.
Hmm.
So it's very, very important to think about which subset our patient is.
So, sir, what is the main difference between, apart from size of NTR and XTR? So, will we need less clips in XTR if we use XTR over the NTR, or it's same?
No. It is basically depending on the length of the AML and PML,
Leaflet length
leaflet length.
and
So,
thick.
how much is the length, sir, you consider for optimal length for the clip, sir?
More than 10.
Yeah.
More than 10. Okay,
Yeah.
sir.
If the PML, sometimes PML is shorter. So if the
Short.
PML is
It is
less
always
than
short.
10,
Yeah.
PML is less than 10, then we should not go ahead with it because it becomes a very complicated scenario then.
Okay, sir. Thank you, sir.
Okay, sir. So let's move to a little unusual case. So a case of AML perforation. Again, elderly male underwent bioprosthetic AVR and 3 months later developed infective endocarditis, admitted and treated for 6 weeks with IV antibiotics. All cultures were negative. Got discharged, but I mean, she was discharged on request or something. I don't know. I have forgotten that. But however, when she landed up to our emergency, he was hemodynamically unstable on inotrope. There was acute kidney injury. ECG was showing LBBV. There was a healed vegetation on the aortic valve, and the gradients were okay, mild AR, and there was a severe MR, and we could appreciate that there was an AML perforation. LV function was fine, and he was intubated and put on mechanical ventilation. Then this is this scenario. So I mean, what to do? The patient was in acute heart failure. Patient is in AKI and there is a free MR through an AML perforation. Multiple cultures have been negative. There was the sepsis, markers of sepsis were not there, and it was all heart failure. AKI, mechanical ventilation, severe MR due to a perforation, and this perforation was almost 8 millimeter in size. And definitely this AML perforation is post-infective endocarditis AML perforation. We had and this is the 3D T, and we see that there is a well-defined round perforation in the anterior mitral leaflet. So we had a detailed discussion, what to expect and how to go ahead. And we told that, I mean, we had a clear discussion that, see, with this kind of mitral regurgitation, with this type of refractory heart failure and all the organ damage, we should at least maybe take a chance with closing this defect. And surgery was absolutely, surgeons absolutely didn't like to touch him. We thought that, okay, we'll try attempt a device closure of this AML defect. There are few case reports that I could find of a device closure of AML perforation, and as a very, I mean, I don't know whether it was a misadventure or what. I decided that, okay, I'll go ahead and try to do. Antigrade wiring of the defect was impossible because of the AML movement and the powerful jet. It could not be done. I could not do it even with 3D. So I decided that, okay, I'll try retrograde and crossing the bioprosthetic valve, which post endocarditis, it became extremely difficult. I could not cross the aortic valve. So what we did is we do a snaring of the wire. So LA to LV aorta and then snared the wire. And after snaring, we put a JR And after putting GR, I took a 1/8 thermo wire and just thought that the high-speed jet it will float. The wire will float through the defect with the high-speed jet, and it happened actually. Lucky for the patient and for me. Then, of course, we snared the wire from the LA. Then passed. Then I deployed a 10 millimeter ASD device in the defect. Sorry. Okay. So this is after release of the device. Post deployment, this is the echo. The MR has the regurgitation has significantly improved. There are some residual regurgitations because what happens is it alters the geometry, it alters the closure dynamics of the mitral valve. So some amount of MR is expected because we have put some weight into a very paper thin structure. However, it was a mild MR, I will say. And next day, as we see that there was good amount of improvement and the device is sitting well. I was also scared that the device might cut through the anterior mitral leaflet. However, it did not happen. But unfortunately, we could not salvage the patient. He was already in end organ damage. So we could not salvage the patient. And after around mm, 8 days or something, after multiple sessions of dialysis and all sepsis, he succumbed. Few cases I could find, and most of the cases they have used ASD device because of the narrow waist, and because of the length of the waist is only 4 millimeter. Other devices maybe will be little wider to put in this situation.
Excellent. Very nice. It's a good attempt, very
Yeah.
educative actually.
Can you explain how the wire crossed through the perforation again? Just not through the coaptation, but through the AML perforation.
No, I took a small this thing. Let me just so I took a small thermo wire, 1/8 thermo wire. So this is the defect. Oh, yeah. So this is the defect, and this is a thermo wire, and it was more or less a blind crossing actually. So what I was doing is I was trying to align the wire towards the mitral valve under TE, of course, and at some point of time it went through the aortic valve. Then we tried to redirect a little bit, manipulated the catheter a little bit. So this is the crossing, exact crossing. It was a stroke of luck actually. There is nothing controllable in this situation. So this Agilis sheath, now here it goes through the defect into the LA. So this goes into the pulmonary vein, inferior pulmonary vein. Then we snared it from there.
I think the closest procedure that I can think of is that maybe I'm not sure, I'm not a structure. So when they do base to tip lampoon, so it is something like that. You're targeting the base of the AML and trying to.
I mean, again, base to, I mean, with 3D we can, but
So
there it
what
is
septal puncture did you use? What location of the septum did you puncture when you were trying to cross it from the LA into the LV?
mid fossa and posterior.
Yeah, because I think your leak was more towards the PML or the aortomitral part.
Aortomitral,
Aortomitral. So
more
it's probably
anterior.
gone
Yeah.
a little bit more superior.
Hmm.
If you go slightly more superior, then it would make it slightly easier to. The more inferior you go, the more difficult it
Hmm.
will be get into the base to get into the base of the leaflet.
Yeah.
If you go superior and slightly anterior, then you can come back
Hmm.
down and go posterior.
Okay.
because only then it will take that curve. Otherwise, it's
Hmm.
not going to take. Even the Agilis will find it difficult to turn so sharp
Hmm. Hmm.
down onto that side. And probably we might have, what we normally do is we would pass two wires,
Hmm.
air one and leave the second wire in, and take the whatever sheath you want through that.
Hmm.
And although ASD device is a good choice, there are the Konar devices is now available, and that's a very, very
Hmm.
nice
Hmm.
device.
Hmm.
What was the size of your perforation? Size of
8 millimeter.
all right, all right. So then that also is important to judge. If you
Hmm.
feel that it is a the Konar is a much softer device. If it is
Hmm.
smaller, then you can even use the ADO2 because it is a more flimsy and
Hmm.
more
Hmm.
easily deliverable device.
Hmm.
The ASD actually limits the movement of the leaflet so much
Hmm. Hmm.
that unless one side is against the wall of the annulus,
Hmm.
if it is actually in the leaflet which gets perforated and not holding on to one side of the annulus, then it becomes very difficult for it to close. So then it becomes palliative and you have to go in and send him for surgery at the end of a week or 2 weeks.
Hmm.
Or but beautiful case, very, very nice demonstration of all the things we have to do sometimes.
Yeah.
Yeah.
Anupam sir, very nice case. I just have my, I just want to say my opinion. If
Hmm.
we see the valve, natural
Hmm.
valve in this OT, it is
Hmm.
like a paper thin valve,
Yeah.
right? So putting any device in that way, it will not hold for a long time. This is what I know, because I also thought of doing such kind of things, but when I
Hmm.
saw the valves in surgery,
Hmm.
paper thin valves, if you put any device, it will have movement of the device, and that is why this device do not hold for long time. This is my thought process over perforation of the leaflet.
Yeah,
Small
exactly.
leaflet,
Huh.
small perforations, yes sir has said Konar is the best device for it because it is very lightweight device.
Hmm.
ASD device is little heavy device,
Little
has a
heavy.
large rims also.
Hmm.
So small perforation, 2 mm, 3 mm, it can works. But if on table, if you see the thickness of the valve, very small. It's like a paper thin valve. Mitral valve works very well, but it's very thin valve. This is what I feel.
Yeah, yeah, exactly. So, I mean, there is not much of literature to review also.
Hmm.
And the case reports I find, I think there are 4 or 5 case reports that I
Hmm.
could find, and all of them have
I have
used.
just last month I've done a tricuspid valve perforation,
Oh,
which is a surgical turn down. That we have closed with a Konar device.
okay,
And I've
okay,
closed one mitral valve with a Konar device, but that was 2.5 years ago.
okay.
That patient is still all right. I have told that in case the leak becomes more, we'll send you for surgery. But
Surgery.
that was more palliative because
More palliative.
it was a surgical turn down. So I said, okay, we'll try.
Yeah, yeah. Even
The
in this
patient has
case,
improved so much. She comes every time and see, मतलब मुझे ठेंगा दिखा के चला जाता है कि कोई surgery आपको कुछ आता नहीं.
even
Sir,
in this case also, the plan was that if he comes out of all these organ dysfunctions and all, he will go for
hmm.
and redo AVR and MVR.
And says you are all lucky that your surgeon says it's not a good case. Our surgeon is so aggressive; he never considered say it for the cardiologist. I will do any case, sepsis, anything. He will say, "I will do. I will do." Our surgeon is totally different. It's like whatever is the
I'm
outcome.
working in a, when you come to private practice, it's the other way around. Nobody wants a bad case on their hands.
Ah,
Government
yes.
service, it's different. वो तो तुम्हारे मतलब he will take your patients also and do something and come back out. In private practice, nobody is going to do high risk cases.
High risk
Come and
cases.
see, हर शहर में एक या दो सर्जन है जो करते हैं, बाकी
Correct.
कोई नहीं करता. It's very different outside. I mean, I've seen, since I've seen both sides. The 30 years I was in government service, so I have seen that that type of work also. So
Yeah.
Anupam sir is our equivalent of AIMS cardiac surgeons.
See, I mean, ultimately somebody has to do something. That is what, if everybody says no.
absolutely.
These are great learning cases. Yes.
Okay, finally, to sum up, the final case is a transcatheter mitral valve replacement. 70-year-old male underwent double valve replacement in 2007, now presented with worsening dyspnea, and the mean mitral valve gradient was 27. So he had basically resting pulmonary edema, And post DVR, around 70 years, there was underlying CKD. Creatinine was around 2. This is the echo, transesophageal echo, severe restriction of the leaflet movements. Leaflets are degenerated, and the 3D is showing rare opening of the leaflets. However, the problem is this, in this case, so factors influencing LVOT obstruction, like, the primary challenge with a transcatheter mitral valve replacement is LVOT obstruction. That is the primary challenge. Of course, valve embolization is another big problem. So these two issues need to be addressed. How to tackle with these two issues? Most important acute problem is LVOT obstruction. So LVOT obstruction can be there because of flaring, because of depth of implantation, orientation, and finally the native parameters are also very important. If the patient is a narrow LVOT, then it's a difficult situation. So either do a lampoon or something. With a transcatheter valve replacement, what happens is that the leaflet tissues of the previous valve, they basically form a tube, and this is the new LVOT that remains. And guidelines recommend that if this new LVOT is less than 200, less than 150, less than 170, then more or less we rule out in those cases. Good cases are more than 200. So that is the problem with valve in MAC, because valve in MAC, again, the orientation of the valve and final placement, final orientation, final angulation of the valve, it cannot be controlled very precisely. In this case, the problem is the neo LVOT was coming around 102, which is prohibitive. We should not do this. But again, all these are surgical turndown. The patient has a mean transmitral gradient of 27. Patient has a resting pulmonary edema. Creatinine is 2. Patient already underwent double valve replacement. But the aortic valve was not that stenotic or regurgitant. However, the mitral valve was completely degenerated. So how to proceed? So this is the current algorithm, that if the neo LVOT is less than 200, then we have to go for alcohol septal ablation, or you can consider for lampoon. And if the neo LVOT is more than 200, we can proceed with TMVR even without lampoon. So some additional procedure is needed if in this case the neo LVOT is 102. So this is basically how the lampoon is done. You take two Agilis sheath, then under 3D echo, we try to target the base of the PML. We enter with an Estato 30 with RF, and then apply cautery and cut the leaflet. So without lampoon, this is the tube that projects into the LVOT. With lampoon, we get a crescentic, we get a triangular area. However, the problem in our case was the leaflets were severely calcified. Even on fluoro, we can see that the leaflets are severely calcified. So lampoon in this case, again, is a more or less a contraindication. And if we try to do too much to these leaflets, the leaflets might get dislodged and embolize. So lampoon was not possible due to heavily calcified valve leaflets. Alcohol septal ablation needs 4 to 6 weeks for result. Patient was in pulmonary edema. Patient was admitted with refractory heart failure. RFA of IVUS, again, a degenerated prosthetic valve in both aortic and mitral position limit the access to the IVS. So these are the practical challenges in this case. So what to do? Deploy the valve and pray. Kissing balloon in LVOT and mitral valve to tilt the mitral valve slightly if there is a severe gradient. Then do a kissing balloon so that we reorient the valve a little bit away from the LVOT. Then if there is a acute hemodynamic collapse, put an ECMO, put a TAVR valve in the aortic position to try to open the LVOT. Otherwise, everything failed, then of course the last resort is to send for surgery. But by the time the patient is shifted to the OT, there will be nothing left to do meaningfully. Again, in this case, we go for a posterior and superior puncture, more or less like the mitral TR. And valve is usually we should try to cross the valve with a pigtail catheter, because if we take a cordie, if we entangle a cordie with a wire, then it's a problem. This crossing with a pigtail catheter more or less takes care of that problem. So try to cross the valve with a pigtail catheter, then pass the wire. So this is a safari wire that is placed. And then we need to do a septostomy. We did a septostomy with a 14 balloon. 14 into 40 balloon septostomy is needed to pass the valve. And finally, we deployed a 23 Sapien S3. Luckily for the patient, post-deployment LVOT was fine. We already had a wire in the through the aortic valve in the LVOT. Just in case we need a kissing balloon, we had a balloon ready also. In case we need a kissing balloon, we'll do and try to tilt the valve a little bit. But luckily for him, LVOT was fine. And this is the valve leaflets, free movements of the leaflets after the valve, and there is no paravalvular leak. Some amount of paravalvular leak has been reported, not very uncommon in transcatheter mitral valve replacements, more common in valve in MAC. So this was a Carpentier valve, so perimount valve, which is a stent. The stent frame gives additional support to deploy the valve. And post deployment, the mitral valve gradient was 3.5. So we could get a good gradient in this case. And this is echo after 2 months, follow-up echo. The mean gradient remains around 4, and we see good leaflet movements of the transcatheter valve. The patient is fine. Patient is doing all right. So indication of TMVR is improving from prosthetic valve dysfunction to mitral annular calcification, especially high surgical risk. Predominant challenges are LVOT obstruction and valve embolization. So always should have a bailout plan. If things don't go well, then what to do? That is more important in these cases. So to summarize that for mitral valve interventions, imaging is the most important factor. Without good quality intra procedural imaging, it is impossible to do mitral valve interventions. Case selection is the most important, because right patient, right anatomy is durable outcome. Then it is a spectrum. Again, many of the times it is palliative also. Complications can be perforation, residual leak, gradient, LVOT obstruction. Multimodality imaging with CT, 3D TE is important. Even ICE is also coming up, though I have no experience of ICE in my valvular interventions. I use ICE for EP, but I have no experience with valvular interventions. Surgical and transcatheter convergence is very important. And of course, finally, we have to take a personalized interventional strategy. Thank you.
Excellent, Anupam. Very, very nice. So the session is open for discussion. It's 9:10. We can have a 5-minute discussion before we close. I see
Yeah.
Indrajit is logged in. So nice to see.
Jain sir. Jain.
Hi,
Sir.
hi. Sir.
Hello, sir.
Sir. Jain sir.
So I think the case was really, really very nice, Anupam. Did you do a gradient across the aortic valve at the end? Because 100
Yes, I have shown. It was the peak to peak gradient was coming around 30.
I think in that situation, you have to choose what is the lesser of the two evils. The patient got a severe MR, even if you create a little bit of an AS, then you probably have to consider. Only thing I was thinking, since you could have probably done septal ablation at that stage, that it would get better with at that time after doing the mitral valve and valve. That was
Okay.
a brave call and probably the right thing to have done in that situation. calcified leaflet, you really can't, I don't know how much you can actually split it with whatever electrosurgery.
And if the leaflet breaks and embolizes, then again,
That is another problem.
mm,
So probably you could have done a septal ablation at
septal
that time
ablation.
and left it, because whatever gradient you had at the end, it was only going to get better if you do
Mm.
septal ablation. That
Yeah.
was the only thing
But
I could.
septal ablation, sir, works in months because initially there is edema
Yeah.
and followed by the fibrosis. So it take
A-
like sometimes
in
it does not because we do alco-septal vision frequently. Most
mm,
of time patients have benefit on table, but around
mm,
one third patient do not have decrease in gradient. We do not give more alcohol less than we give only less than 1.5 alcohol in all our patients. Fibrosis take time. It takes at least 3 to 6 months for
yeah.
the.
Another problem is in this case, especially that creatinine was increased, patient was in pulmonary edema, and
No, no,
many of these.
that's absolutely the right call. I was just thinking
Yeah,
what more.
yes, yes. No, I mean, RF probably would have been a better strategy, but then doing an RF to a degenerated aortic valve, which will take 2, 3 hours again,
It's not.
The RF, sir, RF from the aortic side, you are saying retrogradely, and then so
retrograde RF.
it doesn't work, sir, because the
Hmm.
septum thick is very thick.
Hmm.
RF through apex, that is a specific needle, that 18 gauge needle that
Hmm.
apex the Chinese used to do.
Hmm.
That works in septum because we use RF for the RVOT muscle, and it takes at least under Kato. One
Hmm.
of our faculty does it. It takes at least 4 to 5 hours, and after that the
Hmm.
outcome is nil. So
Yeah,
RF
that is
for
it.
muscle, I would say, doesn't work much because you have to give a lot of burns everywhere. Is red. And at the end, nothing significant reduction is there. This is
Another
what I.
another technique is the sesame technique, where I mean, like HCM, the sesame technique, but again, it needs lot of manipulation through the aortic valve. So,
And the reason I was suggesting, when you do a septal ablation for hypertrophic cardiomyopathy, you typically have a triphasic response. Initially, you get a fall,
acute reduction, yeah.
then it will go up again, and then
Hmm.
later it will come down again.
Hmm.
So you reassess at 6 months, and we have
Hmm.
about nearly 80 cases follow up.
Hmm.
And so we are pretty good at it. We've got this one. So if your acute gradient was high,
Hmm.
that's what I would have done.
Yeah, yeah.
Hmm.
Because your acute
Definitely.
gradient would have come down,
Hmm.
your LV would have got decompressed at that time, and
Hmm.
with time it would have accommodated, and it would have come down in the long term as well. It's just meant because sometimes you may be faced with that situation. You are not in a situation to do a lampoon, and you do
Yeah.
small neo LVOT, and you have a sick patient, and you have to do a valve in valve. What do you do then? This is what I would have done. I would have,
Yeah, sure, sure.
I would
Alcohol
have done
septal
the
ablation
ablation
is the
and take
reasonable
what you
answer.
get. Take what you get after that.
So I just one doubt is you were saying posterior superior puncture. So SVC is the superior most structure, IVC is the inferior most structure, aorta is the anterior most structure,
Hmm.
and the
Hmm.
posterior.
Hmm.
So if we say superior means towards the SVC. I think
SVC.
from the two
Hmm.
third from the IVC, one third from the SVC,
Hmm.
and most of the time it is a thick septum there. If you see,
Ah,
right, sir, Anna, it is a thick septum. It's not
thick
a thin
septum.
septum. Thin septum comes after fossa.
Yeah.
After fossa, correct. So most of the time we say, okay, we'll take puncture there, but it's very difficult to take puncture in the thick septum. You,
So, superior part of the fossa is what we
yeah.
should practically target, not the mid fossa.
Yeah, so a
Thank you, sir.
great discussion. I think most of the time it refers to which segment of the fossa you're going to go into only.
Hmm.
You really can't puncture the thick part of the septum, whatever you do,
Hmm.
even if you do electrosurgery, because the trajectory is unpredictable.
Hmm.
Even if you puncture the superior part, when you floss, you'll end up tearing the part of the septum which is closest to the fossa. The thick
Hmm.
part
Yeah,
will
yeah.
remain thick. You know, only sometimes if you do have very, very good electrosurgeons with you, I mean, you can touch the cautery to the back end of the needle, allow it to go through, put in a safe sept wire or something inside it, and then try and cross and then dilate with a small balloon before you actually take the dilator across, because it's not going to go even along with that. So you put in a coronary wire and then try and keep enlarging the hole, etc.
I have done in some cases RF ablation. I mean, with no, not RF, with cautery.
Cautery.
Just position the needle, transeptal needle and then touch the cautery. It immediately goes.
True, true.
But we have to
Sir,
be 100% sure, otherwise it will puncture wherever it touches.
sir, we do not have, let's be honest with you, we do PTMCs a lot, septal punctures a lot, and PVL and TMVR a lot. And our experience is like the weakest link between the fossa. The fossa is the weakest link. So we always try to enter through that link. We never thought of, okay, we see in SVC, IVC, but from SVC, from drop down, okay, here's the place we see the good pulsations. We just poke it, okay, it went. That's it. In mitral, we do not have experience of mitral clip, but in all the cases of mitral paravalvular and TMVR, we are till now it's 100% success. It's not like in mitral clip we need space, but in all other procedures like TMVR and PVL, we are lucky. Maybe we are lucky enough to have the procedure success is there with us.
TE will give us a very good guidance where to puncture. So when we are going for a structural intervention, TE will definitely help us.
Yeah, so for BMV and for TMVR, you have got so many other things with which you can manipulate, because you have
Yes,
a
sir.
wire over which you are taking your device.
Hmm.
For a mitral clip, your clip has to cross on its own.
Hmm.
So not taking it over a wire. You don't have the comfort of putting a super stiff wire inside the LV and taking your hardware over it. So there is a problem. Since the clip goes alone, there's no support. So your puncture has to be perfect, absolutely perfect. Chalo. Anupam,
Thank you, sir. Thank you, sir.
for some wonderful cases and lots of learning. And likewise, thank you to everybody for joining. I think we
Thank you,
had a
sir.
very nice session, and we've seen a fabulous spectrum of cases presented by Anupam.
Thank you, sir.
Any
Thank you,
congratulations.
sir.
Looking forward to many more sessions like this.
Sir.
Thank you very much, everyone. Good night.
Good night,
Good
sir.
night, sir. Good night.
Good night.
Night, sir.
Great, sir. Thank you, sir.